So Dr. Ahmed Samei Huda works as a consultant psychiatrist in the National Health Service in a deprived area to the east of Manchester in the UK. In addition to the general adult psychiatric patients, much of his clinical work is devoted to the early intervention in psychosis service. Although he's from Scotland, he's lived in England for half his life and has also spent about a year working as a psychiatrist in Australia. He's the author of The Medical Model in Mental Health, An Explanation and Evaluation, and he has an interest in the philosophy of mental health. Away from work, he is a Liverpool FC fanatic, and he's hopeful that Scotland will return to the World Cup. Over to you, Sammy.
All right. Hi. First of all, don't buy my book, your students. It's too expensive for you, so don't worry about that. The second thing, obviously, I'm ready for the game today. The third thing is Glaswegians tend to speak a bit fast. So if I'm speaking too fast, you can't make out. I can't see the comments at the moment, so just give Will a nudge and he'll tell me to go back and repeat the stuff. Now, I did this talk in 45 minutes earlier today, so I'll try and do it a bit more slowly. So I was probably a bit excitable. Okay, so when I was doing this book, doing the research, I spent several years researching this book. The question about whether psychiatry and medicine continents apart, and a lot of the time I was doing the research for the book, it was in the shadow of the Scottish independence referendum, and then after I published the book a couple of years ago, it was in the shadow of the Brexit referendum. And I suppose it's where the continent metaphor comes from. It is something supposed to be apart from a bigger whole, WHOLE. And one of the interesting things about the separatists, I suppose, in both arguments, although this happened on both sides, both in unionists of both sides and the separatists particularly, what I noticed that values trumped information. So even things that are clear-cut or likely to be true were dismissed because they went against the values of, say, often the separatists. And it still happens now in Scotland. So they will say things that, oh, they'll be able to have their cake and eat it. And a lot of this also applies to psychiatry, because a lot of the points made across that I think I address here, the people who make the original points don't change their minds, because it's more about, it's not a view they have based on sort of information, it's a view based on their values. And it's a bit like, I don't know if you have any friends who are like into these various conspiracies, you can't change their mind. Now, so the metaphor here is to do with like medicine. So if you think of general medicine as like the heartland, Germany of Europe, and that's a heartland of medical practice, isn't it? So the idea about psychiatry, is it like, if you look at the map, Italy or Norway? In many ways, Italy is the cultural heart of Europe, but geographically, it's sort of at an extreme of the continent of Europe, isn't it? As is Norway, but still part of the continent. Or is it like the United Kingdom, which used to be part of Europe, geographically, then the sea came in, and politically as well, and now no longer, but it's separate from Europe. So is psychiatry like United Kingdom, separate from the rest of Europe? So the big subject, but I'm going to address two particular issues, which is diagnosis and treatment. So first of all, I'll talk about why I'm doing comparison of psychiatry with general medicine. Secondly, I'll start discussing about diagnosis, how we use classification, how do we diagnose, what is the role of diagnosis, what is the nature of conditions that we label with the diagnosis, how do psychiatric and general medical treatments compare, and then some conclusions. Okay, and if I'm going too fast, if you get well, give me a nod. I'll just go back and cover something. Okay, so I've addressed some of the issues about medicine, about its central heartland of medical practice. One of the things about psychiatrists is that we're medical doctors, and medical doctors tend to be highly regarded in society and seen as being scientific. And this has gone back thousands of years, even when we weren't very scientific, really, and weren't much good. It's a traditional role we have inhabited. And for people who are who like to attack psychiatry or current psychiatric practice, like antipsychiatric professional psychologists and critical psychiatrists. It's a sort of a hurdle they want to get across, is to say, oh, well, you shouldn't put these psychiatrists in the same level as other medical doctors. They're not the same. It's not like medicine at all. Okay. So one of the things they'll talk about is diagnosis being unscientific. Now, the thing is, they use terms in the sort of slightly ambiguous terms. So they mean it's unscientific, but what they mean is, and I will address this later, diagnosis of psychiatry often not explanatory. But science isn't just about explaining things. Sometimes it's also being descriptive. They'll say psychiatric diagnoses are invalid. And by invalid, they mean a particular definition I'll come to later. But they're hoping to get across the sense that it's invalid as in not worthwhile or should be discarded. And they say it's got little usefulness, utility. Other things, they'll say the treatments are ineffective, they're not cures, that we think we're curing disease with our medication, but we're not. And I said before, general medicine is the best comparison. It's the same, generally the same purpose. So the same, one of the purposes of medicine I saw on a paper would be to reduce unpleasant experiences and to prevent the cessation of experience, otherwise known as death. We've got the same purposes and we use the same model. One of the models is that we assess patients, we try and recognize what type of problem they have, and then apply evidence from that, recognizing the type of problem. And that evidence used to be based on our own experience, like thousands of years ago. So one of the purposes of classification, one of them are common, is administrative, but we'll talk about other reasons. So one thing is if you're handing over a problem in your, when you're doing your handover in shifts or writing a referral to another, from a GP specialist or whatever, what they want to know is allow communication between professionals. They allow groups, so you're kind of getting a sense, you're conveying information about the type of problem the patient has. You also allow groups to be defined for research, to gain information on things such as a range of likely outcomes, responses to treatments, biopsychosocial features, maybe causes of what the problem is. And one of the ideas of having a standardized classification is that hopefully you reduce the kind of chance of abusing it, so that, for example, people with can abuse to kind of like label people who are difficult as being mentally ill or something like that. But even if you have an international classification, local practices can go against that. So in the Soviet Union, if you didn't believe in communism, they said you had schizophrenia and medicated you and gave you ECT. So the diagnosis functions as a sort of bridge. So you've two types of sort of knowledge. It's like a procedural knowledge, how to talk to a patient, how to gain important information, how to examine them, how to do lab tests and interpret them, and semantic knowledge, which is about all the different problems that you might face, what can cause them, what can happen as a result, how would you treat them, what would they look like? And that what they would look like is a sort of bridge between that, how to assess patients, and then what's the nature of the problem. That's your link through diagnosis. And diagnosis links like information related to specific conditions, as well as, I said, I've noted how to assess the patient and come to recognize what problem they have, the clinical knowledge, as well as your knowledge about health and illness and disease, so things like your pathological and surgical side. Okay, so when you're classifying these problems that patients have, there's kind of three things mainly: what they share with all of the patients, what they share with some other patients, and what is unique to the patient. Now, if all you do is talk about what they share with all of the patients, you can't basically do the same thing for everyone, and you don't know what the prognosis is, because everything's the same. If you look at what they share with some other patients, you do get some discriminative information on prognosis and treatments. If you just just look at every patient as being completely unique, you can't learn from one patient to the next if they're completely unique. So in fact, when you're assessing and treating people, you actually have to look at all three things. All you do is look at what they share with all the patients. You've got no idea about the prognosis and treatment. You just do a generic, same thing for everyone. So what you need is what they share with some other patients to get some sort of information that discriminates in terms of prognosis and treatment. And then there's also what's unique to a patient, and you can't base treatment on that because you can't learn from one person to the next. So basically, you need to do is all three, essentially. But classification does what patient shares with some other patients. Next slide. So now we're looking at the new information. So what is a diagnosis? Well, it's an abstract concept, as I said, that summarizes complex information about particular problems that a patient might have. Okay, it's not a thing, and it's always provisional. Doctors aren't very good at that, but sometimes they hold on to the diagnosis in dear life. But you have to always be prepared to leave it behind. And it's important to notice that people's problems, you can classify them with the diagnosis, but people are not the diagnosis. Although we've got a bad habit in our language of saying things like schizophrenic, leper, epileptic. Okay. And diagnosis can have negative effects in people's lives. For example, they might not be able to join the army, might not be able to drive, they might get a lot of stigma. And people say that diagnosis is disease-based, but it's not actually a disease-based model, it's a pattern recognition-based model. Okay, next slide. So why do we use, our diagnosis comes in categories. So if you think of like your medical textbooks, you know, you got your chapters, neurology, nephrology, gastroenterology, cardiac. So if you think of them as like a tree, conditions of tree, and they've got branches of the tree, which are different specialties, and then you've got the stems and the leaves. So the diagnosis is like the leaves, and it's sort of organized in categories, and that's got kind of cognitive economy. We tend to think in categories. And the reason we have that cognitive economy is because we work under pressure. You're tired, it's the middle of the night, you've got loads of patients to see, loads of patients in clinics, only 15 minutes, 30-minute appointments, whatever, 10 minutes to GP. So, and we've got to make kind of snap decisions about things. So what we need is a classification system that doesn't take much thinking around the structure of the classification. We can just sort of plug and play it. And the categories we use are what they say prototypes. Even when they have written criteria, in clinical practice, we tend to use prototypes. So what that means is you have a sort of central idea of what that diagnosis looks like, and then you've got unusual presentations of that diagnosis. Think of a bird. Think of a bird, like think of a sparrow or an eagle or something, or a robin. That's a typical bird. But then you think of atypical birds like ostrich or penguin. They take a bit longer to recognize as a bird. Or think like mammals, whales. So a lot of periods of time, people thought whales were fishes, rather than, you know, part of the mammalian family. So that's how in clinical practice people tend to recognize a diagnosis. Does it resemble in their mind what the prototype of that diagnosis is? Okay, next one. Next slide, please. So this is my like codon anticodon type diagram. So the doctor, she'll examine the patient, she'll look at the patient's lab test results, look at any kind of other notes. From that clinical assessment, using her clinical knowledge, she'll get a clinical picture, and then she'll match that clinical picture to the closest matching sort of clinical picture, the range of diagnoses in her head. And this can happen very fast, even in psychiatry. And then people match in the head to what they think is the best matching picture, and then they confirm or deny it, try and find information to confirm or deny that. So that happens very fast. That's how we tend to work in clinical practice. Next slide. So diagnosis is quantum, as in it's uncertain. It's hyperlinked, so it's in a seed. So it's a few bits of word, one word or a few words, and that links out in your head when you're thinking of it. All kinds of information, like how it might present, what the differential diagnosis might be, what kind of other diagnosis conditions you might see at the same time, likely to be associated with it, what are the possible complications of the diagnosis, what are the likely range of outcomes, what kind of treatments you're going to get, what kind of responses. Okay, next one. Next slide, please. So from the slide, one of the common criticism of psychiatric diagnosis is not scientific. The heterogeneous constructs, that means there's quite a lot of difference between each case, even though they've got the same diagnosis, a lot of difference in symptoms or signs or whatever like that. They're not clear-cut syndromes or diseases, okay? So they're not clearly separate from each other, and they're not clearly separate from health. And that's one definition of valid, is that you've carved nature's joints, you've identified a condition that you can clearly distinguish it from other conditions, and that you can clearly distinguish it from healthy states. Other issues are they say, well, there's high rates of co-occurrence. So Someone with depression often has a diagnosis of anxiety. So say, well, how can it be depression if they also have anxiety? So that's one of the issues to say. And they said, well, a lot of psychiatric diagnosis, and this is actually true, the diagnosis in itself doesn't tell you what caused the diagnosis. So Samei Huda, one of the critical psychiatrists, always said, medicine, the diagnosis should name the cause. So I asked him, I said, so what's the cause of pyrexia of unknown origin? He still hasn't come back to me with that one after many months. So I'll come to that point later on. Next slide. So how do we classify people to diagnosis? Well, it's between 1 to 3 kind of structural metastructures that we look at. So one kind of point of similarity might be a similarity of clinical picture. And these diagnoses tend to be descriptive. So you can have 1 to 3 of these. So you can have clinical picture, changes in structural processes, or causes of these changes in structural processes. And you can have between 1 and 3 of these, 1, 2, or 3. That is a basis of classification. So if it's just a descriptive one, like a lot of the psych diagnoses don't describe common changes in structure and process. They just describe similarities of clinical picture. But this is also common in general medicine, hypertension, type 2 diabetes, etc. But also functional medical disorders are quite common as well, like IBS, CFS, ME. Then you've got changes in structure and the processes, and these are more explanatory about what's happening. This change in structure process seems to be associated with causing the clinical picture, but not always. So in Alzheimer's disease, there's a debate at the moment whether they, fibrillary tangles and plaques, whether they're actually causing the problems or whether they're just a sign of something else that's causing the problem. But patients tend to have that common structural process change. In general medicine, type 1 diabetes, no insulin or very little, MS, Parkinson's disease. And then finally, causes of change. So like if someone's got a TB or infection, or they've got an injury. And in psychiatry, maybe if they've got hypothyroid-induced depression. Okay, but that's less common in psychiatry. Next slide, please. So when you're at medical school, you'll often be taught broad medical problems like off their feet, unconscious, chest pain, that kind of thing. And in psychiatry, things like, oh, they say they're hearing voices or they're suicidal or something. And in your head, they teach you a list of things to do to identify what maybe the underlying condition might be that causes it. So they give you a kind of like initial management plan, and then becomes more specific once you get to the proper diagnosis. Next slide. So I've given some examples there: off their feet, chest pain, suicidal, aggressive, poor memory. Next one, thanks. So this is generally what people think of when they think of a diagnosis, a classical diagnosis, disease and syndrome. So syndrome means to run together, which means that these clinical features should associate or cohere. And then this idea is you've got the classic valid diagnosis where it's clearly separated from other conditions and it's clearly separated from health. Next slide. So examples here: type 1 diabetes, MI, TB, UTI, what they call melancholia, which is a specific type of depression, Alzheimer's disease. And some of these are going to appear later on in other things, but this is generally what people think of: organic psychosis, DTs, Veniker-Korsakoff. Next slide. So this is based on what's called Sydenham, who was English Hippocrates, I think, in the 16th century. So his idea was if you could identify unique clinical syndrome, and in his phrase, it would be the same from Socrates to simpleton, then you identify like a unique disease process. So you've got unique disease process produces unique clinical syndrome, and then when you're a clinical research, you identify unique clinical syndrome, and then you work backwards to identify unique disease process. So that's a one-to-one relationship each way. Okay. So he identified malaria, although he didn't know it was malaria, and he identified a treatment for it. 4-day ag, fever every 4 days in the swampy Essex. It was swampy in those days. And treatment of a quinine tree, the bark of the quinine tree or something like that. But obviously you couldn't see malarial plasmodium. Now the problem with this idea is that, as you know, in medicine, there's no one-to-one relationship. So TB and syphilis are great imitators. They can produce multiple clinical syndromes. And then you've got a particular clinical syndrome like chest pain, and it can have multiple causes. So, but this is a classic idea. Next slide. Actually, very commonly in medicine, what you have is you have a spectrum of attributes. And then it's somewhere along the line, someone will draw a line and say everyone in one side of the line is healthy and everyone in the other side of the line, oh, got another chat, is unhealthy. All right, sorry. And there's not much difference between people just either side of that line. We have to draw a line somewhere in order to identify people, you know, as cases to treat or to research. Okay, next slide. Oh, I think we've missed a slide. There we go. So these are quite common in medicine. High blood pressure, type 2 diabetes, high cholesterol, hyperlipidemia, acne vulgaris. Most examples of common mental health problems like this, like anxiety, depression, etc. And some people say psychotic-like experience in the community. I like that, overlap with psychotic symptoms and psychotic illness in this sense. And if you look at what the symptoms of what's called the personality disorders, if you look at them, actually they vary throughout the community. Some people have 1, some people have 2, some people have none, some people have 3, some people have 6, you know. And at some point you draw a line, say everyone above that's got a personality disorder, and everyone below that doesn't. Okay, next one. So this one is spectrums of condition. And so when I went to medical school in the last millennium, that makes me sound like methyluzolene. So we just talked about bronchitis and emphysema. And now I think they just teach you about COPD, don't they? Because they recognize a lot of people have features of both. But they include conditions where the whole condition in the community, when it's present, is on a spectrum. And then we draw lines between different exams and then say everyone in one sector is one diagnosis 1, everyone in second sector is diagnosis 2, etc. And this may or may not have a clear demarcation from healthy people. Next slide. So example, some people think of TB as a big spectrum. I mentioned COPD. Some people have tried to say that diabetes, the 2 different types on the spectrum of each other. Acute coronary syndrome. So at one level, you've got kind of angina, then you've got unstable angina, then more severe NMI. Inflammatory bowel diseases can be hard to separate. Connective tissue diseases, seronegative spondyloarthropathies, and there's an overlap between psoriasis and inflammatory bowel disease, I think in terms of sacroiliitis. Parkinson's disease to Lewy body dementia, they're not separate conditions. In Parkinson's, if you have, for example, you have dementia both. If you have Parkinson's first, then the dementia, it's dementia, Parkinson's disease. Lewy body disease, if you have the dementia first, then the Parkinsonian features, then it's Lewy body dementia. Then you've got the spectrum between frontotemporal dementia and motor neuron disease. Where the particular lesions are, that's the name of the disorder. And then psychosis. Some people think of psychosis as one big spectrum. And you've got bipolar disorder, says blue of the rainbow, and then schizophrenia is red, and in the middle, orange and yellow, you've got schizoaffective. Okay, next slide. Now, this is even more complicated. This is when you've got a kind of spectrum conditions, when you've got like a group of underlying processes and networks creating multiple aspects. Okay, so, and then different aspects are labeled as different conditions. Okay. And the reason you do that is it might be a different sort of attribute. So we'll talk about metabolic syndrome. If you've got high blood pressure, that blood pressure is different from high blood sugar. But also might be because the treatments might be slightly different. So you might give an ACE inhibitor, ACE receptor inhibitor blocker, ARB, for hypertension, whereas for type 2 diabetes, you might give them metformin. And the complications may be slightly different as well. So the eye disease might be slightly different between hypertension and type 2 diabetes. But at the same time, some of the treatments are common. So for metabolic syndrome, your treatments are going to be things like not be a Glaswegian, so eat healthily, do regular exercise, etc. And that's common to all kind of aspects of metabolic syndrome, isn't it? Okay, next slide. So examples of these are metabolic syndrome, autoimmune and inflammatory disorders, myeloproliferative disorders. Often people flip sometimes between the different kind of diagnostic categories. I've put personality disorders because often people have got more than one, because the kind of processes and events that lead to people being diagnosed with personality disorder are common, like things like childhood trauma, difficult upbringing experiences, etc. Internalizing disorders, so that's anxiety and depression. Often people have got anxiety, have also got depression and vice versa. externalizing things like substance misuse and some types of personality issues. And then you've got the dementias, which are like vascular, Lewy body, Alzheimer's. Okay, so these different disease processes often co-occur in the same patient and interact with each other. And it depends on what's the kind of majority disease process that they get that kind of diagnosis. Okay, next slide. I'm doing a grand tour of medical conditions. Injuries, we're almost finished this grand tour, don't worry, but injuries, so these are external events or forces that cause some sort of damage or disruption. Obviously, it's things like, fractures, being stabbed, being crushed, burns, that kind of thing. But also mental health, you might talk about reactions to acute or chronic trauma as well. And that's a very common cause of mental health problems. Next slide. And finally, there's a whole ragbag of conditions that are regarded as being of interest to healthcare professionals. Okay, they're not regarded as illnesses or diseases, but it's felt like health professionals offer some benefit. Okay, so there's some states associated with increased risk or health-related adverse events, such as pregnancy, childbirth, or a psychosocial stressor, where they may benefit from some support. So nobody in the sensible would regard pregnancy as a disease or an illness, but it can cause disease or illness. And obviously, if childbirth, there can be various complications. And there was from Edinburgh, 19th, 20th century, was that woman doctor who found that antenatal clinics reduced adverse health outcomes into like maternal and child death. There's also other things where health professionals thought to have useful skills or can offer other benefits, such as access to clean facilities or equipment, specialist equipment, things like termination of pregnancy, cosmetic surgery, adjustments to new situations. So obstetricians, obs and gynae people do terminations because they said if they don't do them, the demand will still be there. People go to the back street, abortionists, and they'll suffer infections, infertility, death. So it's better it's done properly in a medical environment, reducing the risk to the mother, to the woman. So the next final thing, things that problems and difficulties where you're seeking help from a health or related professional, and sometimes you need to get that help. They need a diagnostic code somewhere to justify it to the insurance company or to the public health administrator. And maybe something like a child behavioural difficulty, which isn't an illness, but they need some sort of help, and they need a sort of diagnostic code administrative purpose. Next slide. Am I going okay? Is it okay, Speed? I'm assuming there's nothing in the chat that it's going okay. So, all right. So we talked about the nature of these conditions and how there's a lot of similarities between psych and general medical conditions. And now let's talk about reliability. And when they talk about reliability, what they mean is how often two different clinicians will agree with each other on the diagnosis. So generally, in psychiatry, when they've done the field trials of the diagnostic systems, they found they got moderate to substantial integrated reliability, which, is 0.4 to 0.8 for most of the diagnosis. So some are much worse. There's some exceptions. DSM-5, their depression category, had absolutely terrible integrated agreement. But they did it in another study and used standardized interviews, and it had almost substantial, something good integrated reliability then. When they look at it in general medicine, they often find the reliability similar to psychiatry. So I've got there a kappa there of 0.348 for diseased joints on an X-ray or something like that. MI or cardiac ischemia diagnosis based on ECG and troponin results, again 0.41 kappa, not great. There was this one where they were doing their MRCP exams, and they correlated the students. Well, obviously they were registrars and stuff, but their diagnosis was the gold standard, which is what the consultant said on the basis of examination, looking at the test results. And it's 0% for bronchiectasis, but 100% for asthma and not having a lung. For pneumonia, it was just more than a third, but the average was about 72%. So what it says, integrated reliability for psychiatric conditions is actually probably similar to many general medical diagnoses. The key difference, though, in general medical diagnosis is they often have tests either to rule in a diagnosis, such as, for example, pneumonia, or to rule out a diagnosis. So they've not been able to find a particular pathology, so they regard it as a functional medical diagnosis. So that's one kind of difference. Next, biological markers of the future. Well, yeah, they keep saying that, don't they? They've been saying that for a while, isn't it? It's like Everton fans saying they're going to win the league. Anyway, sorry. Sorry for any blues in there. Fusion energy, cold fusion energy. We've got fusion energy, cold fusion. Many psychiatric diagnostic constructs are heterogeneous. That means that two different patients, same diagnosis, can be very different. But I'll come to you in a minute. Another thing to notice about diagnostic criteria, because they're not often based on descriptions, they're indexical. It's how you recognize it rather than what the actual disorder itself is. It's how you recognize it. So it's a bit like measles. You recognize measles by the rash, isn't it? But the disease is the actual particular virus, isn't it? Or like an MI. So we used to have 2 out of 3 of enzymes, ECG changes, typical history. When we say typical history, I mean typical history for white Western male. And now it's CKMB plus 1 other. But that's not the actual MI, isn't it? The MI is a dead heart cardiac muscle because it's ischemic, but it's how you recognize it. So the diagnostic criteria uses indexical rather than what the disorder it is. Many general medical diagnostic constructs are also heterogeneous, and they use this what they call polythetic. Polythetic means it's no one criteria is necessary, but it can be a mix of different criteria. And I've given some examples there: MI, rheumatic fever, autoimmune conditions such as MS, SLE, seronegative spondyloarthropathies. So again, it's an issue in general medicine. Next slide. So the utility of diagnostic constructs is often underestimated. Now, utility is context specific. So if you're seeing a few patients, the same patients every week for an hour, 50-minute hour for psychotherapy, office hours, maybe diagnosis is too simple. Remember we said like diagnosis is cognitive resource light. Whereas if like me, you're seeing patients in 15, 20-minute, 30-minute appointments, or you haven't seen the middle of the night, I'm still getting middle of the night to see patients. I need something that's simple and robust. So for some people, diagnosis doesn't have much use. But for the way I work, for most psychiatrists work, it is useful. So for example, bipolar disorder versus unipolar depression. I know if I give someone with bipolar disorder antidepressants, that good stabilizer or antipsychotic, there's a good chance I'll send them high. Lamotrigine is more useful in bipolar depression than unipolar depression. Bipolar versus schizophrenia. Well, people with schizophrenia are more likely to have a worse prognosis. I think it was like 76, 80% recovery rates, 5 to 7 years for affective psychosis. And I think about 35% for schizophrenia. People with schizophrenia are more likely to have cognitive impairment. They're more likely to have what's called disorders of self, which is kind of like these kind of weird experiences that I don't have time to go into right now. And we know that lithium is more useful for bipolar disorder core symptoms than it is for schizophrenia core symptoms. But the thing is that diagnosis is only just the beginning of your treatment plan. You do a broader formulation. And in general medicine, they still get other information as well, don't they? Like CURB-65, pneumonia, Glasgow Coma Scale, the greatest mnemonic in the whole of medicine. Of course, I'm biased. DAS-28, rheumatoid arthritis. But also when you do your post-take ward rounds, you also give information to the patient that is presenting the MI, like, do they have heart failure as well? Are they a smoker? You know, what's the socioeconomic background? These things are of importance in how they develop the disorder, but also the prognosis and treatment. Next slide. I think you can hear my wife talking to the dogs there. She's not talking to me. Next slide, please. All right, so this is quite a complicated slide. So there's a psychiatrist called Wincrief, produces a lot of highly skewed and accurate information. But one of the things she claims is that psychiatrists use disease-centered prescribing. I.e., they think that they're curing disease with their treatments. And she didn't ask anyone. So what I did was I did a survey of my colleagues in Penine Care. And so essentially I asked them about psychiatric medication in general and asked about it in certain situations, such as antidepressants for depression, methylphenidate for ADHD, and thiamine to prevent Wernicke-Korsakoff's in alcohol withdrawal. Okay, and so there were kind of three basic four answers. One answer is they don't think medicine should be used. But the three main answers was disease-centered model. For example, I think I'm using antidepressants to reverse a disease process in depression. A drug-centered model. So the drug-centered model is that drugs are harmful, but some of the effects might be regarded as useful to reduce distress. So she would say that antidepressants blunt emotions, and that people find that useful initially if they're really overwhelmed. And it's no doubt that antidepressants do blunt some people's emotions, but in some people they do have a mood elevating effect. That's how they can cause mania in some people. But Moncrief doesn't think they cause mania, but I've seen people who've gone manic. So compared to her assertion and reality, I choose reality. And then the third type of idea is outcome centered. That's sort of empirical, what we call empirical. And empirical is demonstrated by the evidence. So research shows that this has been shown to be effective for this type of condition, but we're not sure how it works. Okay, so back to Sydenham, he would give them these people with 4-day fever the bark of the willow tree or something like that, or something with quinine in it. He didn't know how it worked, but it seemed to help. Okay, so in fact, what they found is that for most conditions, most psychiatrists tend to think in the outcome-centered way, the empirical way. They don't think they're reversing disease. They do think in some patients there's evidence of benefit, but they're not sure how it happens. The one exception is Venica-Korsakov, where there's clear biological evidence that they've got a thiamine deficiency for whatever reason, they're not quite sure why. And that if you give them thiamine, you do help. Oh, I've noticed there's 2 charts. Oh yeah, that's the ones I've seen, yeah. The cynicism. Okay, so the next one, please. Next slide. Oh, okay, so another criticism is that I had a patient mom today saying, you don't know how these medicines work. And I said, that's true. We don't really know how they work. Most psychiatric medication, we're not sure how they work. And for many medical medications, we do know how they work. But some of them we don't. So for example, thiazide diuretics are very effective in high blood pressure for lowering blood pressure and for reducing difficult complications. The problem is that we actually don't know how it does this. Either reduce blood pressure and therefore then, or to extension, how it prevents complications. Now, you have theories written down as facts in your pharmacology textbook, but really we don't know. Other examples include D-penicillamine, gold for rheumatoid arthritis, and pyrazimide for TB. And most of our treatments aren't disease modifying. They're not addressing a disease. They seem to be symptomatic in some way. They reduce the symptoms without addressing whatever the underlying causes is. But that's true about, and also unknown methods are common in medicine. Next slide, please. So another argument may be that they say mental illness is not defined, so there's no point using diagnostic constructs. So this is an article in the BMJ saying, well, since we don't know what mental illness is, we can't use the concept of mental illness. Well, this is like hogwash. In fact, the concepts of disease and illness in general medicine aren't defined either. There's no watertight philosophical definition of disease that doesn't involve values. So a disease is basically any change in structure and process that has been shown to be associated with a state that we don't value. So, no, in your A&E department, people coming in with ill, the casualty officer doesn't say, well, since illness and disease isn't defined, I'm not going to do anything. You know, it's just ridiculous. Doctors are practical people. We get involved. But the thing is about the values that decide whether something is a problem are more likely to be shared in general medicine than they are in mental health. Although sometimes people, like, for example, if you ask the population, almost as many people as will for general medical conditions, they say schizophrenia is a problem. But when you come to patients, often their values are like, they don't regard themselves as having a problem. So there's a discrepancy there. That's more likely to say in psychiatry than in general medicine. But the issue is that psychiatry is the most complex medical specialty. We deal with the most complex object in the universe. So I've put the mind and the brain here as one, but there's still debate as to the exact relationship. There is no objective measurements of mental content. The closest we can get to is, I think it's with the MEG, magnetic encephalogram. If you put a big kind of like scanner or MEG scanner on your head and they show you a film, by your brain waves, they can probably reasonably accurate at guessing which part of the film that you're watching. And that's the best we can get, really. Next slide. So, back. So, oh no, go forward again, sorry. There we go, yeah. So values will always be used to decide what thoughts and behaviors and experiences are illness or disorder. Okay, so what we're not going to be able to do is do some sort of lab test and then decide what's abnormal thoughts and behavior. We have to decide what's abnormal thoughts and behavior first before we associate it with lab test outcomes. I said in general medicine, there's greater agreement of states being illness and disorder, and 70% of decisions in general medicine made using results from lab tests because it's much easier to measure the function or state of the rest of the body. But even in medicine, up to 40% of referrals to specialist medical clinics are functional, and they use lab tests to rule out other conditions. And stigma exists for some general medical conditions like epilepsy and leprosy. I think I'm coming to the end. Next. The prospects of improved treatments are greater in general medicine because you've got a greater understanding of what causes them and what are the mechanisms involved. And then also how to manipulate them. Now, psychiatry is regarded as uniquely influenced by big pharma, but it's not the case. I mean, if you look at what's called the Sunshine legislation states, they show the different specialties that are influenced by industry, including equipment manufacturers. And psychiatry is well down the list. Cardiologists, general physicians, surgeons, etc., are much more influenced by drug companies than psychiatry is. And part of that's down to no new drugs, really. In the 90s and the early 2000s, when we had new drugs out, there was quite a hefty amount of big pharma influence. Probably to the same level as a lot of the other specialties, but not more than. But since we don't have many particular new drugs, big pharma's not interested. But nobody ever sits and talks about cardiologists being corrupt, etc. It's really about values because they think psychiatry is somehow invalid, therefore they should have no influence. We should have as little influence as possible. And the other thing is that, remember, we're classifying problems, not the person themselves, but the personality disorder diagnosis is the most problematic because it's very personal. There's no more personal than personality. I think that's the final slide. Try again. Oh yeah. Just one more final slide, I hope. So hopefully I've shown that many critics of psychiatry don't stand up if you're saying that psychiatry is not like completely different from general medicine. It's sort of like the overlaps. There are some differences, but they're differences of degree. Some of these criticisms persist. One of these may be because people are ignorant of medicine. Their idea of medicine comes from maybe watching TV shows where everything's clear-cut and there's drama cures all over the place. But this isn't really an excuse for critical psychiatrists who've done a medical degree. They should at least have some sort of residual memory of the complexities of medicine. But other examples of persistent errors that people will make, diagnosis assumes mental health problems exist in neat categories, but DSM clearly states they don't assume that mental health problems exist in neat categories, but they're using categories for the pragmatic reasons that I suggested, often to represent areas of spectrums. A diagnosis assumes biological causation, the absence of clear evidence. Again, DSM and the International Classification ICD both say we don't assume that at all. There's no assumption except when one has been clearly identified. Another common criticism is call it biomedical. Psychiatry has been biopsychosocial since at least the 90s, since I've been doing it since the mid-90s. And it's in our curriculum if they look up the facts. And like general practice is very biopsychosocial. So why do people continue to make these persistent errors? Sometimes it's a lack of knowledge. Sometimes it's a guild war. So there's a kind of like competition. Well, historically, psychiatry used to dump on the clinical psychologists. And it's not been so much like the past few decades, but a lot of clinical psychologists have that kind of residual memory of that. And therefore, they persist in the guild war. And some psychological people don't like to change your mind in general. So if you've got any friends who are into conspiracy theories, you never convince them because facts aren't interesting to them. I think that's the last slide anymore. That's it. You'll be pleased to know. Hey. So, someone said, would psychiatry help if it merged again with neurology? That's an interesting question. So people say, oh, there's no test for psychiatric disorders. And I say, well, let's first of all start with the dementias. And they say, well, that's not a psychiatric disorder. And I say, well, apart from general practitioners, which doctors are most involved in helping people with dementia? It's the psychiatrists. Therefore, why would we be saying something that wasn't psychiatric disorder? If we merge with neurology, would involve becoming more medical, wouldn't it? And neurology, I mean, neurologists see a lot of people with uncertain causes of their conditions. That's true. But perhaps they're not as focused on psychosocial as we are. And Freud started off as a neurologist, didn't he, with the neurology stuff? But he then mutated into something else, didn't he? So in America, you often have joint neurology and psychiatry boards examinations. But I think, and I know that some patients said they would rather be treated by neurologists because neurologists would be hard on the pharmacology and they felt they'd be treated better. But I think a lot of the conditions we see aren't necessarily diseases, are more to do with psychosocial factors or traumatic reactions to trauma. So I think that requires a different sort of skill set maybe to neurologists.
I think that's a really interesting point about the neurology thing, and I've heard people say that. I've heard people who argue, or students who would like there to be dual training. So you'd like to, if you're doing like neuropsychiatry, for example, and I've heard neurologists say that in the future they think that these things are going to be linked. And I think it's kind of funny that you mentioned Alzheimer's, that I think it's funny that where the separations do lie between psychiatry and neurology. And I feel like there's things maybe that are in psychiatry that the neurologist maybe would prefer, like Alzheimer's, and then there's maybe things like chronic pain that the neurologist would rather the psychiatrist dealt with, because it's almost along that kind of.
The thing is with Alzheimer's and neurology as well, it's in the early stages, the neurologists are very interested, but when it's in the more advanced stages, the kind of issues are more about things like dealing with psychological issues, dealing with stress, burnout, multidisciplinary working, care planning. And these are the things that psychiatrists are probably better at than neurologists, because we do it with like everyone really, whereas for them it's less of a sort of everyday skill. So maybe that's probably why the psychiatrist is still involved.
Yeah. Oh, brilliant. Thank you so much for taking us through that, Sammy. I think it's so relevant, all that you've spoken through there, especially for kind of students who were learning about all this kind of stuff. And it's definitely something that we don't really get the time to think about. We've got these sense of labels, probably more so in other specialties other than psychiatry, is these kind of unchanging monolithic things that are kind of to be learned, and we learn in terms of learning cases and learning sets of things. But actually one of the things that I've found quite hard coming into doing a medical course compared to doing a science course is actually the idea that like the symptoms and things that we see are kind of tools, or they have specificity or sensitivity in terms of diagnostic value is quite underexplored. And I feel like there's a lot of certainty in what people say, and like you said, there's very little inter-rater agreement between diagnoses in psychiatry and even in other diseases as well.
There's decent amounts of inter-rater agreement, but they're not. I mean, they're similar between medicine and psychiatry. The difference in general medicine is a test, but the other issue is that in psychiatry, it's often you don't do it on the specific symptoms. It's sort of a gestalt. It's a prototype that they resemble in your head. As well, like if you go into like, so if you in A&E you come into someone in their 60s and 70s, you see someone sitting up in their cubicle in their bed and they're breathless and they're maybe a bit blue around the lips and both their ankles are swollen. You're thinking congestive cardiac failure as soon as you see them, and then you think that in your head within 2 seconds. Then you're trying to like do for and against. And a similar thing with psychiatry, you'll see a patient, you think, oh, is it this or that? And very quickly, in a few minutes, we try to find out why. But the thing is, like science is an interesting example. So in science, you'll have protons or molecules or types of energy. And these are sort of independent of ourselves, aren't they? There's no humans involved. They will exist whether they are or not. But illnesses happen to people. And medical problems happen to people, and people change them. People will express them in different ways. So when I was working in Ayr in the West Coast, so they come up to Ayr because it's a seaside resort, and they'd come up from the south of Scotland, Stranraer. We're in the west, Stranraer's a bit more south, and they'd say, "My child's hingy." I had no, what do they mean? What does hingy mean? And they went, "Clingy." Oh, clingy, right? I know what it means. So it's the same thing, but like just a completely different regional term for it, just 30 miles down the road. So yeah, so protons, types of energy, that kind of stuff, molecules, that happen, that's exact in science, isn't it? That is independent of us. Whereas illnesses, medical problems happen to people. And there's a whole thing about how they happen and how they interpret and how they express and how we pick them up and how we go with it. And so people are trying to explain to us what's going on in them, and they'll use language that, they might not use our language, but they might use the same words. It's all a bit of it's different. It's different, for example, than measuring beta radiation or looking for H2O molecules or anything like that.
Mm-hmm. Sammy, that's really, really, it's been really great. Do you have much time to answer any questions? I know Liverpool are.
That's fine.
Are they playing now?
I'm sure I've got it in the TV. I can always rewind it if they've scored.
Okay, fine. I assume they haven't scored then.
I'm not sure. I don't think we've kicked off yet, but I'll check afterwards and I'll rewind it.
If you want to shoot off at any point, then
that's fine.
Then feel free.
Do you want to? You can send my PowerPoints on to people if you want.
Yeah. I can do that. I can do that if that's okay with you. So if anyone in the audience got any questions, if you do, then please write them in the chat, and we can ask them.
There's no feedback link to Phil, but if you send any feedback to Will, and I'm sure he'll send them to me.
Yeah.
Minus any swear words, hopefully.
Yeah. And we'll try and get those out. So any questions based on what Sammy said would be great. I think one of the things I wanted to touch on was kind of something we're not specifically touched on the talk, but I think last week we were learning about sort of medically unexplained symptoms, and I found it quite funny that it's actually, we call them sort of medically unexplained, but actually they are quite often explained by sort of psychological things. And we're sort of having this discussion about this terminology, and we didn't really come to a conclusion as to what it meant. And I said it kind of implies that there's this kind of dualism in medicine where the psychiatric, psychological problems are not linked to the medical problems. I want to know what you think of that.
Well, what you see is it's a whole contentious issue. So by linking them to psychological issues, many patients don't like it because they feel you're saying they're put it in their head. I think sometimes it might be to think that, well, by any branch of medicine, if you've got a psychological issue, it can worsen your response. So if you've got pain for any reason, whether it's identifiable or not, if you're anxious or depressed, that'll make the pain worse. So sometimes it might be better to think of psychological factors as exacerbating factors rather than causative factors, because patients get very upset. The thing is that like there was one study that showed like medically unexplained, but what they mean biologically unexplained factors, problems are commoner in primary care than medically explained. Depending on, in very advanced states where they just do loads of tests, it's maybe quite less often. But there's a whole, you see, there's loads of people with these, we don't understand why they have these problems. It's very common, but because they don't fit because we feel as if we know everything or most of what there is to know about the body, we get a kind of sense of sort of, this can't be right, this can't be true. I know how the muscles work. I know how the brain works. It's not fitting in with my model of how the brain works. Therefore, it can't be true. But the thing is that all our knowledge is uncertain, and there's bits that we don't know. And we're making the assumption that people's problems are always related, framed onto an exact biological framework. We just don't know. You see, historically, and we go back in time, prehistory, if people had problems, they went to the equivalent of the priest in that prehistoric society or early historic society. And then the concept of healing as healers probably diverged from that, and we were sort of in competition. And so what our kind of like USP would be, we will attend to the body and the priest will attend to the spirit. So because it has to be a body to be our problem, we're kind of like have to relate everything to the body, but people might have problems. It might be the body, it might be something else. But the problem is, because as a society, we think the problem has to be of the body. If it's not of the body necessarily, then we think it's an invalid problem. So basically, like you said, it's dualism. So there's Ahmed Samei Huda, you'll know him on Twitter. I called you Liv as a LivPsych. He's done a recent bunch of papers. One by Dan Lee says that medicine's got dualism, mind and body. They're completely separate. And if we can't work out what's going on in the body, then it must be one of mine. But basically what it is we assume we know much more than we do. And so when people present with things that we don't understand what's going on, it causes like what I call it white coat panic. We feel it's attacking our scientific credibility and our principles. And therefore that causes us to feel uncertain inside. They feel uncertain and we don't like feeling uncertain. So we attack the patient in a way. So yeah, functional disorders, we call them functional, but they're fascinating. And they're just a whole set of conceptual issues that we can't sort out. And we won't be able to sort out for the time being, but yeah, they're very complex.
I think the thing about uncertainty is really interesting. That's something we've been exploring this year as part of our teaching. Just to go back to the sort of title of the talk about them being continents apart. I guess we've talked about dualism. Do you think that is the problem really? Is that people see psychiatry as very different because it's just sort of this innate dualist problem that they have?
Yeah, psychiatry is different because medicine works in a lot of assumed priors that you can't have in psychiatry. So I would say we're still part of continent medicine, but we're more like Italy or Norway. But I'm going to say Italy because the food and the weather is better than Norway. I think the weather's terrible in Norway, and I'm sure they'll try and convince me Norwegian food is great, but I'm not convinced. But yeah, so psychiatry doesn't assume it's sort of givens like the doctor is always the most important person in the team, or the doctor is going to be the one that's going to sort the problem out, as well as other priors like it must involve assumed prior, it must involve a biological problem. You know what I mean? So all these kind of priors are up for grabs in psychiatry. So that way it appears different. These problems are there in the background in all of medicine. They're just more obvious in psychiatry. Therefore, it's seen as different. It's a bit like in a family. And you've got the one who's obviously off the rails or having most trouble, but everyone in the family's got issues. But it's the one in the family who's most got issues gets blamed for everything. They can become the scapegoat. So psychiatry becomes a bit like a scapegoat for all these kind of issues that are throughout medicine. Oh, big pharma. Well, it's actually a bigger issue in other branches of medicine, but they lump it all in psychiatry, for instance.